Gift, we just can't see all your slides, the whole slide. That's better. Morning, everyone. Welcome to UCT-Africa Virtual ENT. This morning, we have our registrar, Dr. Gift Salimo, presenting on malignant tumors of the palate.
Good morning, everyone. Just confirm you can see my slides now.
We can see them and we can hear you. Thanks, Gift.
Okay, thank you very much. Good morning, everyone. My name is Gift Salimo. I'm one of the registrars at the University of Cape Town. Today, I'm going to present on malignant tumors of the palate. Basically, I'll start off with a clinical case which we managed at one of our tertiary hospitals, and then take you through a brief discussion about basically management and just the pathology itself. So I have no disclosures. Consent was obtained from the patient, and my content is referenced at the end. This is the presentation outline. I'll start off with the case presentation, which then I'll go into the discussion, which comprises of introduction, epidemiology, etiology, and risk factors, and also highlight clinical presentation of most common malignant tumors, and then how to wake up a patient resulting in management, and then I'll give you a conclusion and reference at the end. So this is a case of a 79-year-old female patient who had no comorbidities, no allergies, was a non-smoker, and did not have any history of alcohol intake, and had no history of previous surgery. So she presented at our tertiary hospital with a slowly growing mass for 2 years, which has progressively enlarged over the past few months, with worsening pain over the past 2 months. She also reported recent significant weight loss. However, she had any feeding issues. So on examination, as highlighted on the picture, you can see that the patient had an oral mass, mainly on the palate, involving the hard and the soft palate. Clinically, she looked wasted. She had no trismus. The mass was about 5 by 6 centimeters in maximum diameter. There were no other lesions in the mouth. The flow of mouth was normal. The tongue was normal. And a flexible nasoendoscopy was done, and it was essentially normal. And the neck had no any enlarged nodes. Of note, she had no cranial nerve fallout. So the patient was seen in our outpatient department and had a biopsy taken, which came back weeks later with a diagnosis of a low-grade polymorphous adenocarcinoma. Patient had otherwise normal blood workup for basic bloods, full blood count, U and E. And we went on to do investigations. In particular, we did a CT scan and a chest X-ray, which was essentially normal. However, on the CT scan, it showed an obvious mass, which was on the palate, with erosion of the hard palate. But mainly the tumor was bulky posteriorly in the soft palate. We also did a contrasted CT, which I could upload here, which just confirmed that the neck had any lymph nodes on imaging. So the patient was discussed in our multidisciplinary team clinic, and patient which comprised of ENT surgeons, oncologists, maxillofacial surgeons, and plastic surgeons. And a decision was made, and the patient was offered surgery with reconstruction. And patient was booked for surgery. So this is a slide highlighting what surgery the patient went through. So the patient essentially had a pre-operative workup, which involved review with plastic surgeons. We had made a decision to consider using an obturator as a prosthesis. So the patient went in for impressions and for just measuring of impressions in case we were going to consider the option of prosthesis. Intra-op, the patient had a wide local excision, which involved partial inferior maxillectomy, a palatectomy, and of note that we had to take margins which were more than 1 centimeter from the primary tumor. And we staged this tumor as clinically a T4A M0M0. Reconstruction with an obturator, temporary prosthesis was done, and the defect was pegged with BIP and sutured together with the temporary prosthesis. The patient postoperatively did very well and was reviewed by ourselves and maxillofacial, eventually discharged with a follow-up date. The patient was reviewed in our tumor board MDT, and confirmation of a low-grade polymorphous adenocarcinoma was done on final histology, and it was noted that the patient had clear margins, and this patient was staged as a P4A M0M0. So progress of the patient she was eventually seen by maxillofacial for a permanent prosthesis placement, and follow-up was planned to be done at another hospital where the patient resides in another province. So that takes us to a discussion of malignant tumors of the palate. So it is important to highlight relevant anatomy when discussing this topic, just to highlight that the palate comprises of the hard palate and the soft palate, and you would appreciate that most malignant tumors will arise mainly in the interface between the hard and the soft, with progression either superiorly into the nose and nasopharynx, posteriorly into the retropharyngeal area. They can also extend to the tonsils and also even to the tongue. And also of note is the hard palate. The bony hard palate can also act as a barrier to extension of malignant tumor superiorly. So it is important to highlight that malignant palate tumors result in significant masticatory and speech and swallowing disturbances, and surgery remains the recommended treatment modality. And of course, with big defects, we also consider reconstruction. Cancer of the soft palate accounts for approximately 2% of the head and neck mucosal malignancies, and half of all hard palate cancers have been found to be squamous cell carcinomas. Non-squamous cell carcinomas, including minor salivary cancers, sarcomas, melanomas, account for the other half. However, in the soft palate, 80% of these are usually SCC, and non-squamous malignancies account for about 20%. The hard palate, mainly over 50% of them are squamous cell carcinoma, and followed by adenoid cystic carcinoma, mucoepidermoid carcinoma comprising about 10%, and adenocarcinoma about 4%, and also anaplastic carcinoma comprising about 4%, and the others comprising 14%. In terms of minor salivary gland tumors of the palate, 25% are benign, and most of these are usually pleomorphic adenomas, and 75% are usually malignant with adenocystic carcinoma comprising the majority of them, followed by the mucoepidermoid carcinoma, adenocarcinoma comprising about 18%, and those mixed tumors about 8%. In terms of etiology, there's been a lot of research regarding what could have caused most of the oropharyngeal and oral cavity malignant tumors, but in particular for hard palate cancer, there is an established link between tobacco and alcohol consumption, especially for SCC. But there is also a very strong correlation between palate, especially hard palate SCC, with reverse smoking, which is usually found in the Asian countries like Singapore and India, and other factors that can predispose a patient for developing palate malignancies include ill-fitting dentures, poor oral hygiene, mechanical irritations, and some brands of mouthwash. So it is important to know and anticipate the progression of disease in terms of to guide management. So a thorough history and a physical exam helps to assess the extent of the tumor. In particular, regarding SCC, extension beyond the hard palate occurs in up to 70% of the lesions, with posterior extension involving the soft palate, with possible valopharyngeal insufficiency and hypernasal speech. Palatal hypoesthesia indicates trigeminal nerve involvement in the sphenopalatine foramen or pterygopalatine fossa extension. And an absent corneal reflex is indicative of possible skull-base extension through the foramen rotundum, foramen ovale, or inferior orbital fissure. This is a diagram just to highlight the sequence of, just to highlight possible extension, just like the previous slide. So dental numbness may indicate perineural invasion, which clearly upstages the tumor stage. And you can also, the patient also can present with middle ear effusion, which is suggestive of nasopharyngeal extension or invasion of the tensor veli palatine muscle. Involvement of the mandibular division of trigeminal may manifest as hypoesthesia along the mandible or wasting of the temporalis muscle or masseter muscles. And this indicates infratemporal fossa involvement. And trismus in advanced cases and malocclusion with pain are symptoms of invasion of the pterygoid muscle. Extension of the gingiva requires also a further assessment. Nasal flow involvement may occur by direct extension superiorly through the palate, and this can easily happen with mainly soft palate tumors, but with hard palate tumors with the erosion of bone, that can also happen. In terms of cervical nodal metastasis, concern is with mainly SCC and high-grade mucoepidermoid cancer. And it is rare in other salivary gland carcinomas, in particular, like our case, low-grade adenocarcinoma. So neck metastases are quite very rare. 30% of patients have nodal metastases at the time of presentation, with level 1 and level 2 being the first echelon of nodal drainage. Tumors of the posterior soft palate can extend to retropharyngeal nodes, and this can give management difficulties. Soft palate carcinomas are usually staged as oropharyngeal SCC according to the AJCC.
Okay.
So soft palate malignant tumors can spread posteriorly, superiorly, like I highlighted earlier. Almost 50% of these patients will present with extension of the tumor beyond the soft palate. And common site of extension includes the tonsils, the retromolar trigone, inferior or superior alveolar process, hard palate, and base of tongue. Extension into the sphenopalatine foramen may result in palatal hypostasis, and in extensive lesions extending into the nasopharynx middle ear, effusion can be a common presentation. Tumor may also extend anterosuperiorly into the pterygomaxillary infratemporal fossa. So this is a slide just to highlight the multitude of ways malignant tumors of the palate can present. In terms of SCC, it can present as an ulcerative surface lesion, and in some patients, it can be asymptomatic in early stages, delaying diagnosis, and in advanced stages, like in our patient, pain is a very key clinical feature. But an obvious palatal mass is commonly seen with bleeding, and some patients will present with foul odor from the mouth. With those patients who have dentures, an ill-fitting denture in a dentaless patients can be an early feature of malignancy. And loose teeth and poor oral hygiene can also be the initial presentation. In advanced stages, especially in soft palate malignancies, velopharyngeal insufficiency can be the only feature that will be seen at a later stage for those that present late with altered speech, difficulties in swallowing, referred otalgia, trismus, and neck mass being present. Minor salivary gland tumors manifest as mainly submucosal lesion with a smooth normal mucosal covering, as compared to SCC, which usually present with an ulcerative exophytic tumor. And as differentials, melanomas and caposarcomas are quite close differentials that you can mistake an SCC of the palate with. So in terms of workup, an office biopsy is the main modality of diagnosis. You take a transoral biopsy with biopsy forceps when the patient is under local anesthesia. Alternatively, you can use fine needle aspiration, but it has its own limitations. And for us, it is important to note that for ulcerative lesions, you should obtain a specimen from closer to the edges of the tumor to avoid a necrotic central component, which can we can delay diagnosis and give you a false negative result. It is important to also scan these patients. Radiological evaluation helps to increase the accuracy of staging, which eventually guides management. And CT scanning and MRI scan are the imaging modalities of choice, with CT scan assessing skull base extension and enlargement of skull base foramen is indicative of tumor invasion. You should get axial images to aid in assessment of extension in the horizontal plane along the soft palate, pterygoid plates, muscles, and infratemporal fossa and masseter space. So CT scan also with contrast is very important to rule out occult cervical node metastasis, and it is especially important for SCC and high-grade mucoepidermal carcinoma. The MRI scan is more accurate for assessing perineural extension along the foramina, and this is especially important in adenoid cystic carcinoma with propensity to perineural invasion. In terms of staging, they're basically staged according to the AJCC cancer staging, and they usually stage as oropharyngeal or oral malignancies, depending on which is the primary site, either hard palate or soft palate. So in terms of treatment, specific treatment of the palate malignancies depend on the location of the tumor, that is hard palate versus soft palate, and the T stage of the tumor, and also the pathological type. Management needs understanding of disease progression, which we have highlighted in the previous slides, and we should have a plan in terms of approach to basically management, in particular surgery and radiotherapy. And then it is important to also preemptively consider reconstruction if it is available in your center. Treatment of T1, T2 malignant cancer, surgery is the preferred treatment of choice. However, radiotherapy can be used with some success as a variable alternative. Small T1 and T2 lesions can be managed with either surgery or radiotherapy. The proximity of the tumor to the bone and potential complication of osteoradionecrosis makes radiotherapy less desirable, but it can be used in cases where surgery cannot be done. So for these T1, T2 tumors, surgery is quite simple with low morbidity and no loss of function. So a simple transoral excision into and including the periosteum is sufficient. And it is important to highlight that a 1 centimeter, at least more than 1 centimeter margin is taken so that you don't have either in positive margins or closed margins on your final histology. And periosteum in these small tumors serves as the superior margin. Periosteum may be spared only in very superficial tumors that are not close to the periosteum. And this decision has to be done on the table. So for these tumors, a survival rate, 5-year survival rate is about 75% for T1 and 50% for T2 tumors. So management of the neck for T1, T2, clinical and radiological N0 neck do not usually require elective treatment, and treatment of N1 neck is usually controversial, with a pathological N1 node considered adequately treated with neck dissection alone when no extracapsular extension is present. However, in some centers, treatment with postoperative radiotherapy is recommended. And also, if the pathological stage of the neck is N2 or higher, a patient need to have definitely a postoperative radiotherapy. In terms of T3 and T4 lesions, they are usually managed with dual modality, usually combined oncological treatment and surgery, in particular radiotherapy, both to the primary site and the neck. And N1 necks may be treated with radiotherapy or neck dissection with comparable results. And it is important that when planning surgery for these lesions that extend beyond the hard palate, should determine the deficit that will result to guide your reconstruction. And huge resections can cause significant pharyngeal insufficiency with problems with swallowing and speech and mastication. So resection of the soft palate can cause significant pharyngeal insufficiency, and because of the dynamic nature of the soft palate, and lesions that invert the palate bone require partial palatectomy with the resulting oroantral and oroanal fistula. So invasion into the nasal cavity of the maxillary sinus requires inferior maxillectomy, partial maxillectomy, or total maxillectomy, depending on the extent of the lesion. It is quite key to highlight that these surgeries have to be planned with reconstruction in mind. Otherwise, if it is not offered within your institution, you might need to consider radiotherapy and spare the patient the morbidity that results from huge dissections. So in terms of surgical approach, a transoral approach usually is done for at least a small and possibly T4A tumors, T3 tumors, and some T4A tumors. And the resection is performed transorally in most of all the cases of palate SCC or palate malignancies. However, with advanced malignant neoplasms, we can also consider an external approach with mandibulectomy or mandibular approach. for those tumors that extend in the pharyngeal space and pterygo-palatal fossa or masticatory space. Reconstruction is key for those patients that would have gone for a resection. So post-resection reconstruction, a basic hard palate prosthesis can be designed with extension into the oropharynx. As you can see on the picture on the right, you can see a patient with a permanent palate prosthesis that would have been designed by the prosthodontist. When a posterior functioning band of soft palate is preserved, the obturator extension sits on the defect. And it is quite phenomenal to highlight that the patient will have good swallowing, good speech, and this can be give you a long life utility in terms of reconstruction after resection. So this is a picture just to show an obturator prosthesis. The first picture shows a defect just after resection. And then second picture shows like a fitting of the prosthesis. And the last picture just shows a permanent prosthesis that is in place with good closure. So other reconstruction methods, you can use microvascular radio for fasciocutaneous free flaps, which can be an alternative for soft palate reconstruction. For small defects, you can use Pico-Fed pad, which is employed as a pedicle flap to reconstruct the palate. But it is, however, important to note that there can be complications of surgery in palate malignancies, in particular, varopharyngeal insufficiency, hypernasal speech, dysphagia, and some patients can actually present with recurrent middle ear effusion from scarring of the eustachian tube opening or loss of function of tensor muscles. In terms of outcome and prognosis, survival rate was found to be associated with tumor grade, and early diagnosis gives a favorable prognosis if management is done early. And the T stage is also a prognostic feature with margin status, cervical lymph node metastasis, and local recurrence. These are just a few contraindications to surgery, so coexisting medical conditions which can put the patient at risk of anesthesia can guide you to possibly consider radiotherapy, and the size and extent of the tumor, and tumors that have intracranial extension are considered inoperable if they are considered inoperable if they involve the brain parenchyma. So in conclusion, diagnosis is essentially based on search for risk factors, a complete ENT examination, endoscopic examination, and in endoscopic examination and imaging is quite key to rule out bone invasion, and MRI scan retains its place as an evaluation of local and regional tumor extension. Surgical biopsy with immunohistochemical study confirms diagnosis and excludes another diagnostic hypothesis. And surgical excision is the treatment of choice, but radiotherapy can also be considered in cases of advanced stage. Reconstruction of the defect after surgery is quite key if it is available, and it restores almost immediately the phonetic and masticatory functions, and it also allows direct visualization of the primary site for recurrence and detection. These are my references, and that's the end of the presentation. I can take comments and questions.
Oh, well done, because it's not a topic that's often discussed. And it'll actually be nice if you can give a more brief presentation at the African Neck Society meeting. You're not going through all the theory, but just posing the questions about how to manage the neck and also how to reconstruct. I think that defect that you showed right at the start. Of course, the other flaps you can use are the temporalis flaps, muscle flaps, and you can use those bilaterally if you don't have have feedback expertise available. But we don't radiate them much. No, it's an oral cavity tumor, and as you pointed out, that you get you are at risk of getting osteoid necrosis of the palate, which can in itself be quite difficult to manage. Have you got any comments from your side? Yeah.
No. Dennis has a question.
So, if Dennis has a question, we're just gonna ask Dennis to unmute himself.
Thank you so much, Gift, for this really nice talk in regard to this pathology. And my concern is quite general, because this area of presentation in my practice is mostly shared by the oromaxillofacial surgeons. So this patient would definitely end up most of the time with oromaxillofacial surgeons. So I really don't see most of these patients, particularly for pediatric population. But for people who have been in practice for quite a significant amount of time, like Prof. Fagan, how uncommon is this squamous cell, the carcinoma of the hard palate in pediatric population?
So how common are they?
Yes. So how common are they?
I say I've hardly ever seen them in the pediatric population. I'm often called for these patients. Well, the Jenny Red Cross Hospital would call me for these cases, but I can't recall being called for probably a decade or more. So they're certainly not common.
Probably the salivary tumors we've seen, not in that area,
Not in that
but
area.
we've seen adrenal cystic CA,
But very uncommon.
Yeah, it's very uncommon.
Any other questions from the floor? Yeah, well, if there are no further questions, thank you very much. Thanks, Gift. That was a great talk, and we'll see you all again on Friday.
Okay, thanks.
Thank you.
Okay, thank you, Prof.
Well done. Very nice.